Good morning. Today we're going to learn a little bit about the community health improvement process. In our last video, we discussed the community health assessment and how the goal of that was to identify two New York State Prevention Agenda focus areas for the local public health system to concentrate on. In this video, we're going to assume that those focus areas have been established, and we are going to move forward in the process to begin to set up the structure uh, for addressing those focus areas and how we go about doing that and deciding upon strategies and interventions. Um, and then setting up the structure for continued monitoring, measurement of how we're doing on getting those things done, and if necessary, adapting our approach to implementation. This is phase 3 of the MAP process. Um, we'll talk about that here in a minute. So that's our goal for today, and I hope you enjoy the presentation. Okay, this is a little cartoon here that you may have seen from some of my other videos. It's explained in some detail in the accreditation basics video, but the idea here is just to show you the context in which we'll be discussing things today. And it's all centered around the Community Health Improvement Plan today. You can see the arrows coming in the CHA, where we'll get our priorities from, and also some New York State Prevention Agenda stuff. We will briefly touch on some strategic planning stuff and performance management and quality improvement stuff, but they have their own videos. So we're not going to touch on those too much. One thing I do want to show you here is this idea that, population stuff happens up at the community level and potentially at the local health system level. And program stuff happens down here, okay? And it's important to make that distinction, and we'll touch on that a little bit today. Program stuff is where the work actually gets done, and we will touch on that a little bit today. All right, so with that thought in mind, and again, if you need a little refresher on the funnel of health, go to the accreditation basics video. I think it's about halfway through that one. Okay, I don't want to spend too much time on this slide, but let's just focus in here a little bit on the CHIP level and the local health system level. Actually, I should probably read local public health system level, so I apologize there. But again, remember, we are getting our two priorities from the New York State Prevention Agenda, the two focus areas. I said priorities. I shouldn't have said that. I should have said focus areas. And those come from the CHA. The CHA makes that prioritization of the focus areas. And now we're trying to figure out what to do with them. And again, who's the we? It's the local public health system. It is not the health department. It is not the hospital. It is not community action. It is the local public health system. And you'll see that as we move on. I don't talk about this side very much of our funnel of health, but just kind of as a little bit of an aside here, notice that, it says strategic plan. And why do I do this? Because on the left side of the funnel of health, it's all about generating marching orders, right? So we're going to figure out what we're going to do. And that's all on the left side of the funnel of health. On the right side, it's like, okay, what has to be accomplished in order to meet what we're deciding on the left side? So you can see here it says the strategic plan. Now, the strategic plan for an organization is here, but it has inputs from the CHIP, right, from the Community Health Improvement Plan. So what I'm saying here is that the strategic plan needs to get accomplished, right? Because that will accomplish what's in the chip. So I don't talk about the right side much, and I probably should a little bit more. But the reason I'm bringing it up here is that's the implementation side of things, right? Like this is where we actually do the work, right? So we're actually accomplishing things on the right-hand side that then feed up the funnel of health to, hopefully make population level changes. All right, with that, let's move on to the next slide. Okay, this slide is just a little refresher to kind of let you know where we stand and what we're working on in this presentation. Um, this is looking at the MAP process, which is mobilizing for action through planning and partnerships. Again, this was created by Nacho, but honestly, this is, what any planning process looks like. Oh shoot, it went a little faster than I wanted it to. We skipped over phase one, but phase one was just building the Community Health Improvement Foundation. We talked about this in the CHA presentation. Phase two is the Community Health Assessment. We also talked about that in the CHA presentation. What we're focusing on today is the Community Health Improvement Plan and continue and implementing such a thing. And this is phase three. This is today's presentation. All of this, whether it be phase one, phase two, or phase three, has an equity component to it. Equity is in the background, or maybe it should be in the foreground. That's kind of up to the folks involved. But long story short, equity is important, and we do a lot of this uh, with equity in mind. And so that's where we are today. We're going to be looking at this phase three. Okay, now to just kind of set the stage, let you know where we're at. So we've established our Community Health Improvement Foundation. We've got folks working together, starting to align ourselves. We have completed our CHA, and we have two focus areas, one with equity chosen, and these come from the New York State Prevention Agenda in accordance with New York State Department of Health guidance. So that's all been accomplished at this point. Now we're going to talk about the Community Health Improvement Plan, how we put that together, and how we implement, monitor, and adjust. So that is the focus of today's talk. Okay, so we finished phase two of the MAP process, and we are looking to move to phase three. If you recall in the presentation on the community health assessment, we talked about this idea of we, right? And you can go back and check that out in the presentation, but we is important. And so, you know, one way to work, and probably the best way to work, although it is a difficult, time consuming, at least initially, way to work, is this idea of collective impact. I had hoped to put in a little video on what collective impact is. Technical issues, I couldn't figure it out. But do yourself a favor, go to YouTube or something, type in collective impact health, and watch a couple of videos on there about what collective impact is. But there are 5 conditions of collective impact, and through our CHA process, phases 1 and phases 2 of the map, uh, we began to address some of these things. Phase 1 was really about beginning to think about this idea of backbone support. So it's the idea that if you get a number of organizations working together, right, there needs to be people in the background to kind of manage and organize things. Okay. and keep people on task and ensure data is collected and all of these kind of things. Maybe help with grant writing and just providing that support. And this in the idea of collective impact, this is called backbone support. Okay, so you have an organization and you need a backbone to kind of keep things up and running. Um, Sometimes that's done in one organization where there might be a number of staff members who provide that support. Sometimes it's done across organizations um, where, again, a number of staff members in different organizations work together to provide support for the group as a whole. And through the phases 1 and 2, mostly phase 1, we would begin to build that backbone support. Okay. Um, Phase 2 is, the beginnings of a common agenda, right? It's a common understanding of the problem and a shared vision for change, right? If we did our community health assessment correctly, we were able to figure that out for a couple of focus areas from the New York State Prevention Agenda. So, that's kind of two of the elements. And what you'll find here is that in the CHIP, and in implementing the CHIP, we're going to address the other 5 elements. And so, one is shared measurement. And earlier in this presentation, I showed, the funnel of health, and we talked about population health indicators being at the top and program measures being at the bottom. Those numbers can be organized along the funnel of health, and they can be tracked, and you can begin to see how programs, and this is over a long period of time, right? Not a short period of time. You can see how programs can begin to change some of those population health indicators. The mutually reinforcing activities, right? This is the idea that, okay, we have some measurable objectives for our CHIP, things we want to address on a population level, right? And those will require different agencies to act, right, on a program level. And all of them working together towards those objectives. And that's these mutually reinforcing activities. But just to mention on this, not only can organizations work individually on activities. So activities, remember, are down kind of on the lower levels of the funnel of health. And a lot of agencies are going to work on those within their agency, but there's no reason why even down at that lower level, agencies can't be working together on the same activities. And you'll see that in your agency, and you'll see these sort of informal partnerships forming amongst staff of different agencies, right? One agency and another agency, a couple of staff members came up with an idea to work together on something. So this is sort of an informal approach to mutually reinforcing activities, and it's a good one. I mean, certainly not a bad one. But those are the types of things that you see, and we want to track those, and we want to get numbers on that stuff. The next one is this, they call it continuous communication. Nobody can communicate continuously, because if you do that, you will not get any quote unquote real work done. So, I would argue that this is more along the lines of, regular focused communication, right? It's the idea of everybody understanding what other folks are doing. And, this idea of building trust and open communication. What you'll see here later on in the presentation is all of this stuff can be supported by some software systems, and we'll mention those a little bit later on. All right, so before we move on, again, do yourself in the group a favor and just do a little Googling on this idea of collective impact, and maybe watch a video or two on YouTube, just to get a sense of what this is about. This is not easy, and there are different ways to work together. You don't have to work together in a collective impact approach. But if you're really trying to change a system, this is probably a good way to do it, the collective impact approach. Okay, now we're going to talk a little bit about making that transition from phase 2 to phase 3. Okay, and hopefully there's been some talk at this point about utilizing a collective impact approach, and that's what's been decided. But if not, there are other approaches that could be taken, and we need to have a sense of what approach we're going to use. At the end of the CHA process, we identified 2 focus areas, and we generally identified those types of organizations that might be involved in addressing that focus area. And this slide here is actually taken from the CHA presentation, and it shows you, okay, we're going to deal with mental and substance use disorder prevention, and these organizations connected by the red lines, in general, these may be the ones that we want to be working on. And my guess is amongst the folks there making the prioritization decision on focus areas, they have a sense of who these folks are, right? I mean, this isn't rocket science. And, here's another example looking at physical activity, right? So, the idea here is to get the right folks initially kind of identified, right? And the right types of organizations. And that's what's being done at this stage of the process. And this would be done at the end of the CHA, right? At the end of that process. And as you'll see here in a moment, we'll need to make a decision on exactly who's going to be working on these things. Okay, so we are still in this transition from phase 2 to phase 3. And at the end of the CHA process, somebody's got to take this and move it to the CHIP process, right? And that's going to be sort of, we're going to call it an interim focus area subcommittee, right? And so there are, I'm sure, some folks who were working on the CHA who have some expertise in the focus areas, who could sit on this transitioning interim focus area subcommittee, right? There also needs to be probably a representative, somebody who can provide backbone support, and we talked a little bit about that, somebody who can keep things going within this subcommittee. And that person will, and we'll see this a little later on, but that person will probably stay on with the, established subcommittee. At this point, we also might want to be thinking, who might sit on this interim focus area subcommittee. My guess is it will probably be a lot of, CEOs of the agencies, folks who were involved in the CHA There might be some COOs and there might be some staff. COOs and staff are probably more likely to sit on the the established focus area subcommittee, but there may be some of them here. And we may be able to get some other folks involved, community. In fact, we probably should get some, at least one person involved from a person with lived experience or something like that. Certainly within the established subcommittee, that's important. So what is this interim focus area subcommittee going to do? They're going to perform a power analysis, or should perform a power analysis, and we'll cover that in the next slide. And they are going to identify actual people to be permanent focus area subcommittee members. That is their job. So they'll go through this power analysis, and at the end of that, it's going to be like, okay, Jane Doe from agency X is going to be recruited to sit on the focus area subcommittee. Okay, so that is the intent of this interim focus area subcommittee, is to sort of turn those focus areas over to the folks who are going to be doing the implementation and are key to that. The CHA is not complete until interim subcommittee membership is established. If you don't establish this interim subcommittee, everything falls apart, right? No focus area subcommittee is established, and the chip isn't created. There's no buy-in from anybody, and it just falls apart, right? And basically, folks forget about it. And to some extent, that is what has happened in the past. And we need to get this transition from phase 2 to phase 3 right in order for us to move forward. Okay, now we're going to talk a little bit about power analysis. And the interim focus area subcommittee is going to use this diagram here to identify those organizations and agencies that should sit on the subcommittee, on the established subcommittee. And it will also allow them to think a little bit about barriers and challenges too. So we're going to start with the power access, and you can see it there. And most influential or powerful, and least influential or powerful, with regards to the focus area that we're looking at. Okay. So it's all focused on the focus area. Okay. So that's what we're looking at, and power. You can Google that and see what power is. There's different types of power: political, resource, charismatic power, what have you. But we're not going to get into that here. Who influences things, right? Who influences what's important? This is a good one. Who is responsible for change, right? And who do they answer to? Okay. So those are all things to think about on that vertical power axis, I should say. The next thing we're going to look at is partners. Okay, so we're thinking about power, and now we're thinking about people who are aligned with change in the focus area. So, look here, it says organization mission. That's kind of stuff that goes into a strategic plan, right? And that's, a lower level of the funnel of health. But we need to be thinking, generally about organizations' missions and where they would lie within the focus area, right? How much they're aligned with the focus area. Who do they serve? Who's the organization's clients? Are those folks people that are ones that would be affected by doing things within the focus area? Who are political influencers, right? Who would support these things? Um, and who are service providers? Okay. Um, all of those are important in determining partners. Partners might also be folks who have resources, data, or other potential ways to support the efforts. Okay, so we want to be thinking about that. And then you have opponents, right? These are folks on the other end of the spectrum who are not aligned with the focus area. So this x-axis is all about alignment, right? If the y-axis is about power, the x-axis is about alignment with the focus area. Who might be negative impacted, who might have an opposing argument to addressing the focus area. Are there organizations actively working against things to be addressed by the focused area? What is their ability to derail efforts? Okay. So when we do this, we should be thinking about generalities. Now, here's the thing. The interim focus area subcommittee, Cattaraugus County, McKean County, small places, right? People know each other, people know the agencies. This, you may be thinking to yourself, this is kind of silly to go through this exercises. We already know. And the truth is, you're probably right. But I think by going through the process and doing it as a subcommittee of 4 to 6 members or so, um, you're just making the obvious conscious and you're agreeing upon things. And there's that's important. All of that is very important. So here's just another, representation of the same thing. Your focus group members, right? Those should be coming most likely from your focus group committee members. Your permanent members should probably be coming from this group. Okay, they got some power and they're allied with what's going on in the focus group, right? And you can see that here. These are the organizations that need to be part of this. And ideally, it's the folks on the ground who are familiar with implementation work, who would be on that steering committee and know how hard the focus group subcommittee, who know how hard things are to get done. Another group that you probably should consider at least getting some folks into the steering committee is the established steering committee is this group. These are folks that are going to support your goals, and they need they need to build their power and grow influence. These are folks with lived experience. These are community groups. There's a lot within the accreditation guidelines about working with this quadrant to make things equitable, right? These are the ones who are going to, um, that we're going to work on achieving equity with. So this is an important group, and they should probably have, in my view anyway, a little bit of representation on that focus area subcommittee. Um, These are folks, I don't want to say you can ignore, but, you know, I wouldn't, this is not where you necessarily want to spend your time. There may be opportunities to do a little education here to move them over into this group over here, um, if need be. But not hugely important because the thought would be they couldn't hurt your efforts too much. The next group is one to be that's important, and these are folks with power who can kind of oppose working within this focus group. Um, do you want them on your steering committee? Geez, I don't know. Um, some might after, well, let's bring them in and hear their concerns and um, listen to them and try to work with them. Yeah, maybe that's a good strategy. That's something that needs to get discussed. Um, Others may say, we need to just be careful of these folks, know who they are, um, and work to derail their efforts. Regardless of what strategy you decide, um, it's probably good to be aware of them because they're going to have some power to shake things up a little bit. So that's where we're at with that. All right. So now the interim focus committee has gone through the power analysis. So they have a sense of what organizations need to get involved. And the next thing we're going to do is talk a little bit more closely about actual individuals. And in establishing the sort of permanent focus area subcommittee, the people that are involved, we definitely need to have those affected, those who have lived experience in this focus area. That is a requirement for FAB, for the Public Health Accreditation Board members, but more importantly, it's the right thing to do from an equity standpoint. We need to make those voices heard. Um, we also want to have the likely implementers, right? The people on the ground doing the work. This, in my view anyway, is like program supervisors. Okay. Um, this isn't necessarily field staff or people doing the, or it could be, people actually really in the trenches. This is kind of like one level up from that. And this is the folks who are, likely doing the work. You definitely want folks who can think about project management, right? What you're doing and working in a focus area is you're implementing. Implementing is all about project management and getting things done. So you want folks with those kind of skills. We live in a world of data, and funding agencies like metrics and measures, and you'll see here moving on that so does FAB, so does the Public Health Accreditation Board. So we definitely need some data skills on this subcommittee. You want folks with resources. This is getting back to the organizational level a little bit. You certainly want representative from organizations with resources so that folks can know what those resources are. As I mentioned earlier, a lot of this is the people on the right side of that power analysis in those right side quadrants. You definitely want to have a representative from backbone support. Okay, so that person might like be the secretary of the subcommittee or something like that. But you need somebody from backbone support to help out with organizing the subcommittee. These are your focus. So the interim focus area subcommittee identifies the people, the actual individuals to sit on the permanent focus area subcommittee. That's what it is. So what is that subcommittee going to actually look like? Well, it should probably be 4 to 6 members, not bigger than that, right? We don't want to, we want an effective team, and that's sort of the standard effective team size. There needs to be a chair to that committee who would work with the secretary to move things along. There's the backbone secretary. This is the team that is ultimately accountable for getting the work done in that focus area. These are the ones who are accountable. And they need to have regular meetings. I'm not giving you a frequency here. That can be decided by the established focus area subcommittee. But you do need to have this communication on a somewhat regular basis. What are they going to do? So the remainder of this presentation looks at what this subcommittee is going to do. And, they're going to set the goals and the SMART objectives. We'll talk about that. They're going to identify appropriate interventions and strategies for meeting those SMART objectives. They're going to do kind of model development, and we'll talk briefly about that. It sounds a little advanced. It's not really. They're going to make sure that they do alignment, which is the mutually reinforcing activities of the collective impact. They're actually going to create their section of the chip, right? And we'll show you that. They're going to evaluate and monitor program activities, right? So that things are moving forward. And if things aren't moving forward, they may put together a quality improvement process. So those last two, evaluation, monitoring, and quality improvement, we have a whole video on that one. That's performance management and quality improvement. Now, it's made for the health department, but it's easy enough to take the concepts and use them for any organization. Okay, so they're going to be doing that kind of work with regards to the chip goals created. So all of these things, literally all of them. So we got 7 of them there. They can be facilitated by using performance management system software. All right. And we're going to mention that. I have a video on the software that the health department uses that was kind of written for our managers and things like that, but that describes that software. Okay. So we will delve very briefly into that also. Okay, as we start this next section, we need to talk a little bit about language. Okay, you may have seen this slide in other videos that I've done, but what you're seeing here is a whole bunch of words that people use when they do planning stuff. Okay, and these words mean different things depending on who you are talking to. Okay, and they represent different concepts. We have to be clear on the language we use, or else there will be confusion. This slide was used for the strategic plan presentation also. It doesn't matter on what level you're doing your planning at. Language is important. So we're gonna define a little language here, and I'll tell you why in a minute and why we use the terms we do. A goal. This is a broad and long-term general statement. Points you in a direction, right? I'm going to increase something, decrease something, maintain something. It is broad. The next one is an objective. And in today's world, objectives are generally thought of as being smart. And what does that mean? Well, they are specific, right? They're not general. They are, you can tell pretty much exactly what you're trying to do. They are measurable, okay? You know, there's some quantitative measure there that can be, you know, easily collected. And that's important, easily collected, right? Or is already being collected. We don't want to have an objective that we're going to spend a lot of time and effort trying to get the numbers on. They need to be achievable, right? We don't want to stop people. You know, we don't want people to think that what they're doing can't be done. It's not good for morale, right? They need to be realistic. I think this is also might be relevant, but essentially they have to be focused on um, on what's trying to get done, and they need to be time bound. Okay, so they can't go on forever, right? We need to get this stuff done. And we'll show you some examples later on in the presentation. And then this activity. An activity is actually a specific task to be completed. So, you know, let's start from the bottom. So we do activities so we can reach our objectives. In those objectives, if reaching those objectives, we meet the long-term goals. And these can be done at any level of the funnel of health, right? And you'll see that in a moment. So why do we use this language? Well, we use this language because this is the language of our software, which is Vision, Mission, Services, Goals. This is our performance management software system. And this is the language they use. Could we use other language? Sure, we could, but then we'd have to do the translation, you know, like the Rosetta Stone, for those of you know, and then you got to do this translation. Okay, I use the term performance measurement here. That means it's an indicator here, or it's an objective here, or whatever, right? We should stick to what our software uses because that's going to help us organize the process. Okay. Okay, now that we've got our established focus area subcommittee, we need to get a sense realistically of the organizations involved and what they do and their alignment with us and the resources available. In previous versions of the CHA and the CHIP within the Cattaraugus County, we listed a laundry list of potential resources, right? And what do I mean by that, right? So we looked at all this stuff and we threw contact information for every organization under the sun, right? And said, oh, this is a potential resource. No, not really, right? Let's be realistic here. Who legitimately is going to work on this? Now, that isn't that doesn't mean to say that we can't reach out maybe later on as things develop to some other organizations. But that should be done when the need arises, right? And as we continue on with the process, maybe as part of quality improvement. So, we need, so the example here is focus area 2, but, we need to know who these organizations are within our local public health system and who the appropriate contact is. So we're establishing our partner profiles for horizontal alignment. If you don't know what horizontal alignment is, go back to the accreditation basics video. We want to know what their primary economic sector is, is it nonprofit? Is it government? Is it business? A mixture of the above. You could get a little more detail here. It's not hugely important, but you want to have a sense of where that organization works in the context of the economy. This is an important one. Who do they serve? All right. What does their clientele look like? Who is their service community? Especially when it comes with regards to equity, right? If we're going to be equitable, we want to be working with partners and organizations that service the groups that we're trying to be equitable with. What is their mission and values? Oh, this is a strategic plan thing, right? Mission and values. So we're dropping down a level on the funnel of health, but we definitely want to make sure that whatever organization we're working with is aligned with, the mission and values of the local public health system as expressed in the CHA, right? And we want to make sure that there's at least some level of alignment there at that organization. And then what are their aligned programs and services? Okay, now we're dropping down another level on the funnel of health, So they're currently doing things, right? These organizations are doing things. What are the goals and objectives of what they're currently doing? And how might those change based on what we're looking to do with the chip, right? And then what are the resources they could potentially share, right? And this is getting to this idea of mutually reinforcing activities. Can they share? Do they have some staff time that they could share? Is there space that they could share? Is there data that they could share? Money, childcare, other services, right? So as we are identifying the different groups, our different partners in these efforts, we want to know what resources they might be willing to share. Resources are thin. We all know that. And, some of this might be shifting resources a little bit within an organization. And, some of it maybe trying to get new resources for an organization to address a chip priority. And maybe the backbone staff could help with that. But, at least there needs to be that discussion centered around resources. So it's these partner profiles that allow us to get a better understanding for our actors within the local public health system and how they can help. All right. Okay, now that we have our long-term focus area subcommittee established, we have a sense of the partners who might be working with us on this focus area. Now we need to think about determining our goals, objectives, and interventions. And here's the truth. The best place to do this is the New York State Prevention Agenda. This is where you have a lot of resources that can help you. So as you're aware, the CHOP process, we picked 2 focus areas, one with an equity concern, and here's an example of one: healthy eating and food security, right? And sure enough, look at that. There's some goals, right? Great. These look like good goals. Look at how they're written. Increase access, increase skills, increase food security. Oh, geez, that kind of sounds like our definition of what a goal is, right? It's sort of pointing in a general direction to do things. So, these are good goals, and these are directly from the New York State Prevention Agenda. And here's some objectives. Increase the percentage of adults with perceived food security. 80.2% is the target. Here's our baseline. This is our year. By the way, this is from the 2019 to 2024 prevention agenda. So all of this would need to get done by, the end of 2024. Gives you the data source for this. Remember the conversations about data. It gives you the data level, right? Oh, and look at this. This is collected at both the state and the county, right? It's important. So this is easy data, right? The state collects this. It's done through something called the BRFIS. And oh my gosh, I forgot what that stands for. Again, I think it's Behavioral Risk Factor something survey. But it's a, scientifically properly designed survey, right? Phone survey down to the county level. So this is good. This is good data we could use for our objective. So now we got a goal. We got an objective. Increase the percentage of adults with perceived food security, right? And oh my gosh, we even have a potential strategy or an intervention. In health, we call them interventions. They might be called strategies. And it gives you a little description. And this description is kind of general, right? You'd actually have to figure out the tasks and other things. And again, that would be further down the funnel of health, right? If we do that, those actual activities and the action plan, that would be further down the funnel of health, probably at like the program level. Okay. But here's an intervention for you anyway. And I'm not going to read it, but you can kind of be reading it as I talk to you. So that's good. So New York State Prevention Agenda gave us a lot of what we need. All right, but so let's start down here at the bottom. These are population health indicators, right? Remember, if you watched the earlier video on the CHA, we had this, little box model: programs affect risk factors, affects health outcomes. So, the risk factors and the health outcomes are sort of population level data. And what New York State is giving you is sort of population level data. When we look at these things, right, if we're getting this data from New York State, we got to look at Cattaraugus County numbers, right? Not state numbers. That sounds obvious, right? Like, why would I be looking at state numbers? I should be looking at county numbers. Our last couple of chips didn't do that, right? If you look at them, and I have, the numbers for our indicators, and I don't know, I hate to say this, I don't know whether they're called indicators or not off the top of my head. They might be called objectives. Again, language, right? But they were taken from the New York State prevention agenda, but they were using New York State numbers, not Cattaraugus County numbers. So moving forward, we need to make sure we use the Cattaraugus County numbers. They are not primary data. Look, I can't stress enough to you, and I stressed it in the CHOP presentation. We just don't have the time, expertise to set up a proper survey to collect proper population health data, right? We can't do that. So we really need to rely on folks who can do that. The BRFIS stuff. Now, that being said, there are data we can create and, down at the program level that are going to help us. But, these are population health stuff, and, let's leave that to the people who are already doing it. Okay, so at this point, I'd like to segue a little bit into talking about performance management system software. We're going to talk about VMSG, Vision, Mission, Services, Goals. I mentioned that earlier. This is the software the health department uses. One thing as a group we may want to think about is this the software we want to use? I have looked at 6 different software systems. VMSG could do what we want it to do. However, if you ask me, in my humble opinion, it is not the best of those 6. I would rate it sort of number 3. There are 2 other ones that I think would do things better at the local public health system level. That being said, we're not there yet. We haven't made those decisions. So we're going to do an example using VMSG here. Okay. So, in VMSG has certain terms that it uses, right? And talks about organizations, right? And there are different ways we could potentially license this as a group. I'm not going to get into those now. It's complicated or somewhat complicated, but we are up here, right, at the local health, public health system level. So we are looking at organizations, and each organization, one way to handle this is each organization would, somehow get a license for VMSG, and they would organize their work in this way, right, with different levels depending on where you're at in the funnel of health. Not going to get into the details of VMSG here, but what I want to get across to you is the hierarchical nature of the software and how it mimics the hierarchical nature of the funnel of health. And this allows us to use this software from the public health indicator level, the population indicator level, all the way down to the program level. Okay. And the software tracks all of that, right? Real quick on VMSG, at any of the levels, right, you can input these things, the vision, mission, values, service initiatives, and those are definitions, what services are provided. An initiative is sort of a future service, if you will. The goals, we know what those are, objectives and activities. Those can be entered in at any level within VMSG. Okay. and that's important. Okay, so let's just do a quick little example looking at VMSG within the Cattaraugus County Health Department and the different levels involved here. So the CHIP, the Community Health Improvement Plan goals and objectives, right? The health department has some responsibility in doing that and making sure that stuff is implemented. It is not, as I think you're now well aware, it is not the health department's responsibility to implement the entire community health improvement plan, but it does have responsibilities. It is a group. It is at level 2, maybe kind of also level 1, depending on how VMSG is licensed. But um, it is a one organization, and so our county health improvement plan is across level 2. That's how we have it entered in the health department. We have our strategic plan. This is the county health department strategic plan. But honestly, if you were using VMSG, right, it could be any organization's strategic plan, right? And that would be across divisions. Now, listen, I understand a lot of the folks I'm talking to here, are lucky to have a couple people working for their organization. You're probably not really doing a whole bunch of strategic planning. You just don't have the time and effort to do that. Um, but my guess is sort of in the back of your mind, right? You kind of have a strategic plan in your head um, on what you're looking to do. It may not be written out or fancy or anything, but within your organization, I'm sure you have some thoughts about where you're heading. And that's I have a whole video on strategic planning in the health department. You can look at it as an example for your organization. But that happens on VMSG group level 3, right? And then the action plans are within group level 3. So this is our various programs and staff, right? And even within the health department, um, some of this is written down, some of it is in people's heads. And especially when you get down to sort of, level 4 or program stuff. So, you can imagine there are certain responsibilities assigned to the health department through the CHIP. And, those get inputted into the strategic plan, which makes its way down to the various action plans within the various divisions. Now, historically, what has been the case is a lot of the CHIP actions have been, not all of them, but a lot of them have been assigned to our health education people. It's just an aside. This slide is really meant for you to just get a sense of how this works. All right, so now we've going to show you real briefly here what this would look like entering into VMSG, right? So starts with the New York State Prevention Agenda. We've discussed that. Gets to the CHIP, and you can see here the goals and the objectives in the service and initiative. And all of this would be stored up across VMSG level 2 groups, as I showed you in the previous slide. So, I'm not going to read these, but you can read them there, and, they look like good goals and, smart objectives, right? Similarly, you make your way down to the next level and, the strategic plan level, if you will, and, you get support CHIP implementation and, you got a nice goal there pointing in a general direction and you got a nice smart objective there. And all of that would be stored across VMSG level 3 groups, okay? Making your way down one more level, you're talking about action plan. you're going to support the strategic plan implementation. Again, you have a goal. This one is not, pointing in a general direction, but it is sort of giving a general verb on what you're going to do, identify, right? But we do have a nice, smart objective here. And it would be stored within the level 3 of VMSG. Okay. So again, making your way down the funnel of health. Finally, the tasks get assigned, staff do the work. And when staff accomplish the actions, that allows the strategic plan objective to be accomplished, which in turn allows the CHIP objective to be accomplished. So that's how that looks in VMSG software. And like I said, there are software that do the same thing. They use different language, but they essentially do the same thing. So strangely enough, all of that data entry is kind of a logic model, right? So, this is taken from the MAP guidance document put out by Nacho, and you can see here, here's your not logic model part. Process metrics, activities. Well, those sound like, those seem synonymous with what we had in VMSG. And you have outputs, right? And these are also, upper level stuff, maybe on the strategic plan or action plan level in terms of objectives, right? And then you have outcome measures, and these are starting to look a little bit more like getting closer to population health stuff. I'm not going to go through all these. I will leave this up for you as I talk so you can kind of look at those. But, again, by entering this stuff into software, you're essentially creating your logic model. And you're making your way from process measures at the bottom to population outcomes at the top. All right. That's all we got for this slide, I believe. Let me just check here and make my way. Oh, geez. All right. My mouse has stopped working. Well, read the slide. Read the outcomes here. And I am going to try to, geez. Shame on me. All right. There we go. I think I got the mouse working. All right, moving on to the next slide. Okay, up until this point, we have looked at how we enter goals and objectives. We determine those using the prevention agenda stuff along with the interventions. Right, we showed you that. We talked about VMSG and entering those goals and objectives and interventions into VMSG. And that basically creates our logic model, right? And we showed how the way that we enter those into VMSG establishes alignment, which is essentially our mutually reinforcing activities with collective impact approach. So we're doing pretty good there. Chip creation. So essentially, by entering all this stuff into VMSG or some other software, you've created your chip, right? We tend to think of these things as paper documents in the past or electronic documents currently. We kind of need to stop thinking that way, right? So these things, these plans now live in software, right? And that's actually a good thing. That allows us to change them quickly and be adaptive. I didn't show you this, but I can print out if need be. I can print out or make a PDF of all that stuff I entered into VMSG. If we really needed a paper copy or we needed a digital copy, we could do that. But essentially, by entering it into the VMSG software or any other performance management system software, we created the chip. It's done, right? So now we're moving on to evaluation and monitoring, and then quality improvement. So let's talk a little bit about monitoring and evaluation. So let's start over here. Long-term population indicators, right? We are not going to monitor this stuff on a weekly frequency, monthly frequency, quarterly frequency. No. Now remember, these numbers come from New York State. We're not doing primary data collection on these. These come from New York State. So we're going, or Pennsylvania or whomever, but we're going to be doing this on whatever frequency they pull their numbers. We're going to look at those, okay? And those can go directly into VMSG or whatever other software we're using, right? They're up on the New York State Performance Agenda dashboard also. I said performance agenda, I mean prevention agenda. Short-term stuff down here at the bottom, we can collect data on, right? As we do our programs, and we'll have to come up with program indicators that we can collect our data on. And those we might, change those numbers on a weekly, monthly, quarterly basis. Those are numbers we might update. And by the way, all these numbers are updated within VMSG. I showed you how to enter in well, I didn't show you how to do it, but I told you that you can enter in the goals, the objectives, the activities, but you also enter in the measurement units, and then you enter in, the number of those measurement units whenever you want to show your progress towards a program objective or something like this, right? So those we can enter in on a more frequent schedule. Okay. So all of the data that we collect gets entered into something like VMSG, right? And so we make our way down from the CHA again to the chip and down to the strategic plan level, entering our data in, hoping that we're meeting our measurable objectives, and then we're going to go to the performance management level and quality improvement. By the way, this monitoring and evaluation, all of this is performance management. We have a video on that. Actually, at the time I'm making this one, we're still working on the performance management video, but there will be one shortly. And it's those actions that get accomplished by our staff as they perform their job tasks. And we actually have a video on that one too, talking about workforce development. So the monitoring and evaluation occurs here at the performance management quality improvement process level. And I refer you to that video. The next slide here that we're going to look at, this is just making the point again that we have less frequent monitoring up here and more frequent monitoring and data entry down here. Okay. And actually, another point on that monitoring, like people actually got to look at the numbers, right? And those are the numbers that should be discussed at focus area subcommittee meetings, like how are we doing on our numbers and what can we be doing better? And that's going to move us into quality improvement, right? Which is the next slide. So we're going to have a presentation on this. It's in the process of being created. But essentially, it's what I just said, which is, how are we doing? How can we do better? And going through this process. So again, we're down at the bottom of the funnel of health here. We're determining our action plan, our implementation tasks and activities. That's the plan part. By the way, some of you may be familiar with this diagram. This is the plan, do, check, act cycle of quality improvement. And this is used across many industries. They each have their different spin on it, but the concept is essentially the same. You start by determining what you're going to do, what activities to take. This is all about action planning. You actually do those things, right? So staff does these tasks. Hopefully the staff is properly trained in accordance with some sort of workforce development plan. I refer to the video on that. Then you look at your monitoring data. So this would be the stuff that we've entered into VMSG. That's your quantitative data on how we're doing to meet our measurable objectives. You're going to speak with the implementers, right? This allows you to get qualitative data, so you can identify improvement opportunities. So you're doing your checking. Then you do something based on the check. So hopefully with the data that you've looked at as part of your check, you sit down with, in this case, it would be our focus area subcommittee, saying, hey, we're not meeting our numbers as quickly as we thought we should be. And, we've talked to some folks, see how things are going, the implementers, and we should make some changes. And you discuss what those changes are, and you come up with, the plan to change how we're doing implementation, and the cycle starts all over again. Essentially, that is the plan, do, check, act cycle. This is our quality improvement. That happens down at the staff level. Now, you're probably thinking to yourself, well, look, I am a focus area subcommittee member, right? Certain activities have been assigned to our partners who agreed that they could do these activities. I don't have any control over that organization and how they're doing their activities. And, you don't. That's probably the truth. But, you're hopeful, right? You're hopeful that you can talk to that organization, show them what's going on, work with them to brainstorm how things might be done better. Do they need more resources? Not like you can necessarily get those resources, but could folks help them out? Maybe some of the other agencies involved, to get the numbers up. All right, so that's the quality improvement part of this, and so that's how we make progress towards our population health indicators. All right, you see my contact information up there. You're always welcome to send me an email, give me a quick call. If you have any questions, thoughts, concerns, you want to talk about this stuff a little bit, maybe I can point you in the direction of some further resources. I'm happy to do that. Both this video and what I would say is the previous video, which talks about the CHOD phase 1 and 2 of the MAP process, they kind of go together, right? And the audience for these two videos is community organizations that might be involved in either the CHA process or implementation and creation of the chip, right? So those two videos are really for you guys. And the other videos in this series are more for the health department itself, but I do think you can get a lot out of those. Just think of your own organization as being the health department. And certainly these videos here, the CHA and the CHIP videos, kind of set the stage for the other videos on strategic planning, performance management, and workforce development. I might also encourage those watching this video to look at the accreditation basics video. It really explains the funnel of health, I think about halfway through. It'll explain to you where the health department is coming from, and that kind of thing. And as a partner organization, it might be useful knowing what's going on in the health department and how we're structuring making our changes. So again, feel free to contact me, and thank you for watching the video.